Next, we will talk about ventricular hypertrophies. We will start with right ventricular hypertrophy. Ventricular hypertrophy occurs mostly with high blood pressure. The high blood pressure will increase the ventricular wall tension, and due to the law of Laplace, the tension of the ventricular wall when is directly proportional to the diameter of the ventricle and inversely with the thickness of the ventricular wall. This is the mechanism that is going to increase the ventricular wall. This is how the stress or the stretch is going to decrease. Hypertrophy of myocyte and an increase in the extracellular collagen matrix. Predisposing factors such as the mechanical, such as the preload and afterload, increase in both, or neurohormonal factors such as angiotensin II or sympathetic nervous system, the mediators that promote the hypertrophy. The diagnostic method that used to diagnose ventricular hypertrophies include physical examination. This is the first and the most commonly used. Next, ECG. However, we have to know that ECG is not the best tool to diagnose hypertrophy. Chest X-ray is much better. Echocardiography or CT MRI, they are the best tool to see the enlargement of these ventricles. Right ventricular hypertrophy is caused by high pressure load due to pulmonary stenosis or pulmonary hypertension. This is characterized by the relatively tall R wave in the right ventricle leads, for example in V1, where the RS ratio is bigger than 1. So the R is bigger than an S. Normally we do have a RS, a small R and a deep S wave in V1. Here, however, we do have a R complex. Usually this is associated with a right axis deviation. Alternately, we do have a QR pattern in V1 or tall R in V3, deep S wave in V5, V6, ST depression and T wave inversion that represented as a strain phenomenon because we do have a repolarization abnormalities. Here you can see the strain, the downsloping ended with a negative T wave. When we're looking at the right ventricular hypertrophy, how the QRS complex looks like the chest lead, we can look at the vectors, how the chambers are activated. First, we do have the left ventricle activation. After, we do have a very tall, very big vector that pointing to the right, and in the basal area of the right that pointing to the up. This is why in V1 we do have a tall R and not as high, not as deep as wave as an R. However, this R is getting taller toward V2, and in V5, V6 we do have a deep S wave, and of course the QRS complex is getting wider. It's very important one to remember that when we do have a deep S in V5, V6, and is not round shape but is deep and the RS ratio is less than 1, we have to think about the right ventricle enlargement. In this ECG, we do have rhythmic heartbeats. That's the rate is around 80. We do have P wave, sinus P wave. The PR interval is normal. The QRS is narrow. And the axis is extremely left deviated. It's more than 120. Looking at the QRS complex, in V1 we do see the R, in V2 we have a bigger R and S wave, and if you look at in V5, V6, the RS ratio is less than 1, representing a right ventricle hypertrophy. Here you can see that downsloping strain phenomenon in V1, V2, V3. Acute cor pulmonale, when we do have a pulmonary embolization, a sudden pressure overload that is stretching the right side, cardiac output decreases because the preload decreased. That causes sympathetic activation, tachycardia. The stretching and dilation of the atrial wall causes fibrillation, atrial fibrillation, or atrial flutter. And due to the right ventricle stretch, that can cause right bundle branch block as well. The QRS axis may shift to the right, sometimes in concert with the so-called S1 Q3 T3 pattern. This can be seen in about 20% of the cases. We do have a prominence S wave in lead number 1 and a Q wave in lead number T3 and associated with the negative T wave. This ECG tracing shows normal rate with sinus impulse formation, rhythmic. The rate is around 1, 2, 3, 4, less than 75, around 65, 70. The P wave, morphogen P wave is normal. PR interval is normal. QRS is wide. The axis is pathologically deviated to the right. In V1, that's the R nudged R pattern, and in V2 the RSR can be seen nicely. On the left side, however, we do see a deep and wide S wave representing a right bundle branch block, a complete right bundle branch block. Looking at lead number 1, we do have a very deep S wave. Lead number 3, only this lead number 3, we do have this Q wave and a negative T wave. This all represents a pulmonary embolization. Chronic pulmonale mostly due to the obstructive lung disease. That's a chronic situation. Usually doesn't produce the classic ECG sign of the right ventricular hypertrophy. Instead of the tall precordial R waves, we do see small R waves in the right to the mid-precordial leads, due in part to downward displacement of the diaphragm and the heart, clockwise rotation, weak R wave progression, as you see here. And low voltage in the all leads. In this slide, we do see that's sinus tachycardia. Here we do see the P pulmonale, the right atrial enlargement, and the PR is normal one. The axis is normal, it's close to 80. Pathological Q wave, uh, it looks like we do have QS complex in V1, V2, V3. However, we do have a very weak air progression and a low voltage in the chest leads that representing a chronic core pulmonale. So this QS complex from V1 to V3 is not a sign of necrosis. This usually due to the displacement of the diaphragm and the rotation of the heart. Next, the ventricular hypertrophies and the left ventricular hypertrophies that we will talk about. Left ventricular hypertrophy, we do have a tall left precordial R waves, a deep S wave in the right precordial leads. There are several called voltage criteria for the left ventricular hypertrophy. The most commonly used is called the Sokolov-Lyons index when we are going to summarize the S wave in V1 and the R wave in V5 or V6, whichever is greater. If it's more than equal than 35 millimeters, that is a criteria for the left ventricular hypertrophies. But if you do see the R wave bigger than 25 millimeters in V5, that alone can be the sign of left ventricular hypertrophy. Or in the limb leads, AVL, if it's more than 11 millimeters, that can be the sign of a left ventricular hypertrophy. And usually in these leads, we do have the strain phenomenon, as you do see right here. Repolarization abnormalities, as we mentioned, that can be seen in ST depression with T inversion and left ventricular strain, often progress into the complete or incomplete left bundle branch block. So when we do have a left ventricular hypertrophy, in V1 we have a RS, very deep S, and in V5, V6, we do have a QR complex where the R is very tall. Left ventricular hypertrophy, similarly to the right one, what we discussed, basically, when we do have a smaller initial wave, that's a septal activation. After we do have a very large one for the left ventricle activation, and still we do have the terminal one as pointing toward the left one. This is why everything goes away from the right side. This is why it is an initial R is a septal one, and after goes everything to the left side, so RS, and the QR wave in V5, V6, and usually associated with repolarization abnormalities that presented as a strain phenomenon. Next ECG tracing. That's the rate is 1, 2, 3, 4. That's around 65. That's a sinus rhythm. The morphology, the P is okay. PR is normal one. QRS a little bit wider. I would say that is wide because it's more than 0.12. So that can represent uh, depolarization delay in the ventricle. Looking at the axis, that's the extremely left deviated. Looking for the pathologic AQ wave, there is no pathologic AQ wave. However, we do see an RS complex all the way to the V4 and a tall R wave in V5 that associated with this downsloping ST segment. So that's a strain phenomenon. So if you summarize, that's a left ventricular hypertrophy.